Hello, everyone. This is Chadi Alraies from Detroit Medical Center. I'm coming to you from Cardiology Update. Today, we're going to go to deep dive to one of the major ACC 2024 trial that was presented in Atlanta. I'm really privileged today to deal with Professor Gregg Stone. He is a professor of medicine at Icahn School of Medicine. Dr. Stone, thanks for being with us.
My pleasure.
Yeah.
Thanks, Chad.
So the trial we're going to talk about today is Relief HF. As we know, the cardiologist now getting more to the venous side and more into the congenital structural procedure. So tell us a little bit about the rationale of the trial.
Sure. Well, the concept of Relieve HF has been around for a long time. And that was that if we can create a small communication between the left atrium and the right atrium, an interatrial shunt, in patients with heart failure, we could reduce left atrial pressure. And left atrial pressure, whether it's in heart failure with reduced or preserved ejection fraction, is the final common denominator that causes dyspnea on exertion. And the left atrial pressure is usually elevated above 25 millimeters of mercury for days before patients are hospitalized for heart failure. So it was hoped that we would make patients feel better and improve their overall prognosis by creating a small shunt. Not a large shunt. Obviously, large ASDs are not good to have, but we're talking about a small shunt with a QP-QS ratio of around 1.2 to 1, which would just decompress the left atrium. And the beauty of this concept is that it's an auto-regulatory mechanism that basically works 24/7, 365. Whenever the left atrial pressure increases, you get more shunting because the gradient from the left atrium to the right atrium increases, so you get more shunting of blood, and that would lower the left atrial pressure. When the left atrial pressure is low, you don't need it, so there's very little shunting of blood.
And this is the, go ahead, sorry.
No.
So this is on top of medical therapy for heart failure.
Right. So the first patient population that we're tested in are patients who have refractory heart failure, who continue to be symptomatic with NYHA 2, 3, or 4 heart failure, despite all best guideline-directed medical therapies and electrical therapies. And so we tested this with one particular type of shunt called the V-Wave Ventura shunt, which is a small hourglass-shaped device that is implanted in a very simple interventional cardiology procedure in the fossa ovalis of the interatrial septum. It takes about 30 to 45 minutes. And it leads to shunting of about 1 liter per minute of blood from the left atrium to the right atrium through a 5.1 millimeter central orifice. So it's a very small hole.
Right.
And we tested this in first pilot trials in both patients with preserved and reduced ejection fraction, where the outcomes look quite good. And we therefore performed a pivotal trial for potential FDA approval called the Relieve HF trial. And in Relieve HF, we randomized 508 patients with any ejection fraction who had, again, refractory heart failure symptoms, despite optimal medical therapy and all other therapies as verified by a central eligibility committee on screening calls before patients were allowed to be randomized. And patients also had to have established heart failure for 6 months, a prior heart failure hospitalization or markedly elevated biomarkers, reduced 6-minute walk times. And the only major contraindications were for patients with severe pulmonary hypertension or moderate or severe RV dysfunction. And we randomized these patients in a placebo procedure-controlled trial, so a blinded trial, to 1-to-1 to either receive the V-Wave shunt or a control, basically nothing. And the operators, of course, were aware of whether or not they inserted a shunt, as were the other people in the cath lab. But the patients were blinded by being deeply sedated, wearing masks and music playing headphones, and then their families were blinded, and all physicians, research personnel, and healthcare people that interacted with the patient outside of the cath lab for the duration of 2-year follow-up were blinded as well.
So it's a purely sham procedure for that group.
It's a sham procedure, right? Now, importantly, we didn't know whether the results would be the same in patients with heart failure with reduced and preserved ejection fraction, because even though they share increased left atrial pressure, the hearts are very different in those two conditions. Reduced ejection fraction, the left ventricle, and often the right ventricle are enlarged. The heart is more compliant, it's more stretched out. The ejection fraction is obviously reduced. In patients with preserved ejection fraction, the ventricles are small and the heart is very stiff, and the problem is filling, which leads to non-compliance of the left ventricle, which raises the left ventricular and diastolic pressure. So we actually stratified the randomization according to a left ventricular ejection fraction less than or equal to or greater than 40%. And that's what we called HFrEF and HFpEF in the study. And that was the only major subgroup that we looked at. So we had two separate randomized subgroups. So the primary endpoint of the study was a composite hierarchical ranking of 4 hard cardiovascular events and then improvement in quality of life. So it was all-cause death, the need for a heart transplant or LVAD, all heart failure hospitalizations, all outpatient worsening heart failure events, and then the quality of life was measured by change in Kansas City Cardiomyopathy Questionnaire. And we followed the patients for 2 years until the last patient received 1 year follow-up. So it was a rolling follow-up between 1 and 2 years, but the median follow-up was 22 months. And so this was a large study that we randomized 508 patients in 94 countries over a 4-year period.
Absolutely. And it's very, I was intrigued by the fact that the patient underwent the whole procedure and consented and had the procedure. The only one was able to identify the device delivered or not was the operator himself or herself.
Yeah, exactly.
And it's also another good factor is they included both cohort of patient, as you mentioned. Although they are different cohort of patient, HFpEF and HFrEF, but it's still included both with a good number to recruit.
Right.
So let's go over the main finding, Dr. Stone.
Right. So the first finding was about safety, and we had a primary safety endpoint, which was the 30-day rate of major adverse cardiovascular or neurologic events relating to the device or the procedure in the patients who were assigned to receive the shunt. And that occurred in 0 patients. So it was extremely safe. And in fact, throughout 2 years, there were no device or procedure-related adverse events as defined in this trial. So a very safe procedure. We had the efficacy endpoint was measured by the win ratio. So it was a hierarchical ranking of those 4 cardiovascular events and then change in quality of life. Mm-hmm. And we did not see a difference between the treatment and the control groups. The results were almost identical in the 2 groups, very similar rates of cardiovascular events and very similar change in quality of life. In fact, there was a fairly marked placebo effect in this study where both groups improved by about 10 points in KCCQ, which is a big change. The change occurred by 30 days and then was persistent through 2 years. So large placebo effect, but the shunt did not lead to an incremental improvement. Now, where it became particularly informative is when we looked at the results separately in patients with reduced and preserved ejection fraction. And there we were actually kind of almost shocked to see a marked difference between those 2 groups of patients. And when I say marked, it couldn't have been more different. In the patients with reduced ejection fraction, there was a tremendous benefit to shunt treatment. There was an overall 45% reduction in all cardiovascular events, p-value less than 0.0001. And the biggest change was a 50% reduction in heart failure hospitalizations, but there were also very favorable trends for 30 to 50% or more reductions in all-cause death, LVAD heart transplant, and outpatient worsening heart failure events. In contrast, in the patients with preserved ejection fraction, we saw a worsening of events. We saw a 68% increase in all cardiovascular events, p-value of 0.0001. So these p-values are very, very strong strength of evidence, pretty much beyond a shadow of doubt. And in that group, we saw a doubling of the rate of heart failure hospitalizations and a tripling of the mortality rate, statistically significant, with big interaction effects. So the interaction effect for cardiovascular events was less than 0.0001, the interaction between HFpEF versus HFrEF and shunt treatment on overall outcomes. And there were major positive interactions for most of the components of the cardiovascular events. Oh. And finally, despite that, we did not see differences in KCCQ, in the quality of life outcome, in either the patients with reduced or preserved ejection fraction, despite the fact that the patients with reduced ejection fraction were markedly benefiting by the shunt. They didn't necessarily feel better. And despite the fact that the patients with preserved ejection fraction were more likely to die and have a doubling of heart failure hospitalizations, they said they weren't necessarily feeling worse until the events occurred. So it really raises questions about how to interpret KCCQ and what it means in these blinded trials and by implication in open label trials as well. So the bottom line is that we concluded that in the overall population across the entire range of heart failure with all ejection fractions, the shunt was safe, but did not provide benefit. However, among heart failure patients with an ejection fraction of less than or equal to 40%, there was a marked benefit, where in patients with a greater than 40% ejection fraction, there was evidence of harm.
This is very, as I said, interesting findings. But again, as you started at the beginning, you mentioned this is completely different cohort of patients. So going forward, how we can implement the findings of this trial going forward for the patient with HFrEF or HFpEF?
Right. So in HFrEF, in devices, of course, this shunt and other shunts, and there's about 10 companies that are developing shunt-like devices for use in the interatrial septum. They're all investigational. So that's the first point. They're not yet available in the United States, although 3 of them, including this device, are CE marked in Europe for use. So certainly in patients with heart failure and reduced ejection fraction, there was strong evidence of benefit. And these were sick patients with a lot of events. 89% per year were having abnormal heart failure-related events in the control group, and that was reduced to about 49% per year in the treatment group. So it was a big treatment benefit.
Right.
So I think further studies of shunts will certainly focus on heart failure with reduced ejection fraction. And the FDA will be considering whether this is sufficient data to approve this device in the United States. Now, the heart failure with preserved ejection fraction is more complicated because there, within the patient population that we enrolled, we saw clear evidence of harm. And we are under the process right now of trying to determine who were the patients that were most likely to have bad outcomes with preserved ejection fraction. And as you know, there are other shunt trials that are going on only in patients with preserved ejection fraction.
Wow.
They're enrolling a much lower risk population. They're enrolling patients with normal cardiac output, normal pulmonary pressures, normal pulmonary vascular resistance, with an elevated exercise-induced pulmonary capillary wedge pressure, who have a lot of other favorable features. And so there may be a very low-risk population of heart failure with preserved ejection fraction that might benefit from a shunt, and we'll have to see what those trials do. The sick patients with heart failure and preserved ejection fraction, though, like we enrolled in our trial, I think that's over. Shunt treatment in those patients should not be considered.
Final question. Now, with these strong findings, as you say, a significant reduction for this endpoint in HFrEF patients, do we need to have a dedicated trial only for HFrEF patients using these shunts, or the evidence we have now is enough to move forward, hopefully present this to the FDA for approval?
Well, I think you'll get different opinions from different people. The conservative approach would say, look, this was the heart failure with reduced ejection fraction was a subgroup from a negative trial. And since you didn't pass the primary endpoint, all other outcomes are hypothesis generating. And that is a valid perspective. On the other hand, this was, again, the only pre-specified subgroup. It was a randomized stratified group. So it was actually a randomized trial on its own. And the p-value, which really represents the strength of evidence, that's what a p-value is, with a p-value of less than 0.0001, it's extremely unlikely that this is due to play of chance. So my own opinion is, and I've asked a lot of people, if your mother was on 3 or 4 heart failure drugs, and 96% of the patients in this trial were NYHA class 3. So they would get short of breath when they'd walk up a flight of stairs or briskly across a room. Yeah. And if your mother's on 3 or 4 heart failure drugs, which most of the patients with heart failure and reduced ejection fraction were in this trial, and was markedly limited based on these data showing no safety adverse events and a near 50% reduction in events, would you want your mother to have a shunt? And almost everyone has said yes.
Yeah.
So that's also my opinion, but of course, we'll have to see if the FDA believes that this is robust enough data to support approval in the United States.
Well, thank you so much, Dr. Stone. This is a great overview of BeAT-HF trial, as well as a new therapy, a new structural or interventional therapy for patients with advanced heart failure. Strong evidence, good number of data, and also a big difference to see which one will benefit, which one will not. Dr. Stone, really appreciate your time and input, and always valuable input on these trials. Thank you for our audience as well as our viewers on Cardiology Update. This is Chadi Alraies coming to you from Cardiology Update. So see us on YouTube, Facebook, Twitter, and Instagram. Dr. Stone, thank you so much for your time.
Thank you, Chad.